Hi, I'm Tari Turner, Director of the National COVID-19 Clinical Evidence Taskforce and an Associate Professor at Cochrane, Australia in the School of Public Health at Monash University. Welcome to the first episode of TaskforceTV. This is an opportunity for us to explain our guidance with the experts and answer some of the questions facing many clinicians currently caring for people with COVID-19. Today, I'm joined by two extraordinary Taskforce contributors to discuss treatment and management of people with acute and critical COVID-19. I'm joined by Professor Carol Hodgson, who's a specialist physiotherapist in the intensive care unit at the Alfred Hospital in Melbourne. She's also head of the Division of Clinical Trials and Cohort Studies in the School of Public Health and Preventive Medicine at Monash, and is the Allied Health Professional Australia nominee on the Guidelines Leadership Group and Deputy Chair of our Acute and Critical Care panel. I'm also joined by Associate Professor Steve McGloughlin, who's an intensivist and infectious diseases physician. Steve's the director of the ICU at the Alfred. He's an ANZICs and ASID member, and my colleague and boss here. He's the executive director of the task force. So thank you both for joining me for our first episode.
Thanks, Tari.
Thanks, Tari.
As we record this, today actually marks 2 years since the very first steering committee meeting of the task force. 2 years. Who thought we'd still be here? Reflecting on those 2 years and where we've got to now, what do you think the key messages are for clinicians who are caring for adults with severe COVID-19 and those who might be in ICU?
I think we've got some great key messages. Thank you, Tari. The National COVID-19 Clinical Evidence Task Force has done a fabulous job summarising the best of the evidence that we have available to us. And I think that it's really being used not just by Australian clinicians, but by clinicians across the world. So, for example, as soon as the results of the RECOVER trial that showed that we were able to use corticosteroids in critically ill patients to improve survival, we could see that that was translated across Australia. And in fact, our group in the Intensive Care Research Centre measured via our registry whether that evidence was being uptaken across Australia, and in fact it was. So I think the message to clinicians is that they are doing a fantastic job. They are trying to keep up to date with the evidence. We can see that they're adopting the evidence as quickly as possible. And I think that the task force is really summarising the evidence in a way that's in nice sound bites so that people know exactly what is evidence-based and what's consensus-based and how they can proceed.
Steve, key messages from you, key takeaways from the guidelines for clinicians caring for patients with severe COVID?
Look, I think if you forgive me, just to do a quick message for clinicians looking after acute COVID, it probably would be to say thanks to them all. It's been a very tricky couple of years, and it is a pretty brutal disease for those group of patients ended up in intensive care. So it's, I think when you think back to 2020, like you said, Tari, we expected to be busy, but I didn't really expect the patients to be quite as sick as they are for quite as long as they have been, some of them. And Carol is more expert than me, but some of the long stay intensive care that's needed to be provided has been pretty extraordinary across Australia and across the world, and people surviving all that. So mostly the key message is to say thanks and well done for what you've had to do. In terms of clinically, I think it's been interesting because at the start there was this big push towards clinical things that sort of wonder drugs would come out for COVID, and then vaccination was obviously being talked about. And what we've seen obviously through the task force is those things have come out. Obviously vaccination through ATAGI and other recommendations has come out, and that's obviously a big game changer. And treatments have come out, but they haven't really translated to treatments at the acute and severe end. So what I think people can take confidence from the guideline is we are screening a huge number of studies, and we're looking for those high quality interventions or disease modifying interventions that really might make a difference. Because we've all been excited by the bylines and the papers and stuff. So there's been a new wonder drug invented or something like that. So I hope that people can have confidence that we can provide that guidance for people when a new drug does come out. Is it going to work, and which population is it going to work for? And then it's about really, we seem to be regressing towards a mean of providing really good, solid intensive care for patients, which I think is really important. And for the clinicians, things like, safe ventilatory parameters and things like that are really important. But also, again, none of us have got the time or the ability to be screening for all those things. And is there going to be something comes out that talks about a change in how we manage patients in intensive care? We know from the data that has come out, things like awake proning, which wasn't something that was really done much before. I think we probably would have laughed at it before, to be honest. Isn't like we would say, well, that's just putting people on their stomach. It seems a bit silly. But as the evidence was able to come out and then grew quite quickly, we saw, as Carol said, in the databases where obviously it was translated pretty quickly to practice. And that, based on the evidence and our experience, that stopped people needing intubation and obviously led to better outcomes that way. So I think it would be keep up with the evidence, but we can help you with that. I think that's really important. Practice good intensive care. And there are some things that are going to come out of this in terms of intensive care practice that probably are going to be translatable to other patients. So I think we're all now, again, with proning, much more confident in that process, which is quite exciting for other diseases, or if COVID, happens to come back for wave, whatever we're up to now.
Interesting that you're talking about proning, and Carol, I'd like to kind of explore that a little bit more with you. Can you just kind of give us a sense of what's different around respiratory support for patients with COVID-19 than you might have done previously, or for other conditions in the ICU and at the severe end of care?
Yeah, certainly. So for the severely unwell patients, as Steve has touched on, the awake proning is something that's really come out as being incredibly important. And at the moment, we have recommendations for proning for at least 12 hours per day, or to encourage patients to, awake prone for as long as possible. Now, that's not something that we've ever really used before in Australia. So I think that that's something that we have learned quickly, has been very beneficial, and that's mainly come from evidence from overseas. And I think that we've really adopted prone positioning in mechanically ventilated patients, which has always been level 1 evidence, but I think that we had not adopted it as well as we should have. And now it's very clear that proning is one of the first line things that we should do with our patients with critically ill COVID-19. And to that end, most of the intensive care units have pivoted and they've developed prone positioning teams. And these teams of people, and, it can be up to 7 or 8 people at a time who are required to turn a critically ill COVID-19 patient. You can have 3 on each side of the patient, a couple at the head end, 1 at the bed end, and, sometimes somebody outside as a spotter as well. So it's really a team effort, and it's multidisciplinary. We have medical staff, nursing staff, physiotherapists. Sometimes the anaesthetists come in to protect the endotracheal tube if we're short on intensive care staff. Certainly during our surges, we've relied on other disciplines to come into the ICU and help us. And I think that that's something that's been incredibly important. And with my allied health hat on, physiotherapy's had a great role in leading some of those prone positioning teams across all of the hospitals. So that's something I'm really proud of, because I think that it's, as a group of clinicians, we've worked really well to make sure that our processes are streamlined and as good as they can possibly get. And we've got better and better at it so that we're quicker, we're more efficient, people are really well trained, we're very careful, we take care of each other, and we take care of the patient really well.
Steve, you mentioned earlier that there hasn't been a wonder drug. We've not found the drug that is going to be the game changer. But can you tell us a little bit about what drug treatments are being used in these patients and what you see as their role?
So I think dexamethasone is, as Carol mentioned before, there's always been a suspicion and probably differences in world practice around profound respiratory infections, especially viral pneumonitis, and whether steroids would work. We're pretty confident from pretty early on that it wasn't really potentially, and I'm going to get myself out of my lane pretty quickly here, but live active sort of virus causing the problem. It's really, as in all sort of sepsis type syndromes, it's a combination of a trigger, which is usually an infection, obviously, in sepsis syndromes, and then some sort of pro-inflammatory cascade that sets off after that. And that's definitely how the patients seem to behave. The virus is long gone, and we still see progressing respiratory failure and worsening lung disease. So there'd always been a suspicion that steroids would work. And, the congratulations of many research teams, ones Carol's involved and other ones overseas, they're able to get the information that the dexamethasone did make a difference and improve survival, which is pretty exciting. Like these trials came out pretty quickly, and so it's been confirmed, and some other data since then, obviously some large registry data as well. Not to downgrade any evidence or to talk about it in a negative way, I guess the challenge for always us in intensive care is that, these are studies done in big randomized controlled trials, which is the best evidence we can get. But then every patient is different, and so we do see patients respond to steroids differently. Some patients develop the complications of steroids, whether that's things like thermopathies, or whether we have seen quite a lot of secondary infections in COVID patients. And we won't know now whether that's because that was going to happen anyway, or because we're giving things like steroids to these patients. But we do know that the steroids made a difference in terms of their chance of surviving their COVID infection, which is the key thing. So I think that's going to be the challenge of more data coming through now. And even things like dose optimization. There's been a couple of studies that have compared doses for steroids, but obviously there's probably more room to move in that as well, to try and get optimal dosing right for these sort of things, over how long and what duration and what sort of end dose we're going to give. Other drugs such as tacrolimus and baricitinib, and I'll definitely get out of my lane if I try and explain how they work, so I won't do that. But I guess these drugs working on inflammatory cascades are really trying to turn off that inflammatory process that kicks off. And we see this with developing worsening fibrosis on CT scans with patients and worsening restrictive physiology. And I guess, again, we're trying to stop that from getting worse. These are drugs that are predominantly invented for another disease that have been found to be effective in COVID-19. So I think, again, we're at a point in medicine, and this is a really common criticism and challenge around sepsis syndromes that Carol would know well about from the guidelines we sit on, where we tend to use these very strong drugs because they have good efficacy across the population. The next step I would love to see, I guess, over the next few years is, trying to work out which patients are they more likely to work in, so we don't have to use these drugs for everyone. But unfortunately, we haven't got to that point yet. So the job of the intensive care team is to give the best treatment we can with whatever drugs are recommended for the time. And then we try and look for the complications and look for which patients are most likely to get complications so we can act early. Unfortunately, the antiviral type drugs probably limited utility for patients that come into intensive care in the more traditional pathway, because patients, on average, after to come to intensive care, it's a little bit harder now that diagnostics have become a bit muddy with RAT tests and symptom-based, diagnosis. But it was usually sort of 7 to 14 days before people needed intensive care, which is usually outside of the window of antivirals thought to be effectiveness. So there's a little bit of data around in the sort of more moderate group, and in many places in Australia and around the world, there are people that are unlucky and get their symptoms and get sick really fast, and that's where antivirals might have a role, but that wouldn't be in the main cohort of intensive care patients, if you like.
Steve, you mentioned earlier, we've got some patients who are staying in the ICU for an extended period of time. Carol, you noted the importance of the multidisciplinary team and the management in that context. I'm just wondering, Carol, could you kind of give us a sense of, what does the journey look like for a patient once they, have come into an ICU, and what does it look like once they're going back out to the ward and home? And what's the role of, allied health professionals in that journey from ICU onwards?
Yeah, that's a great question, Tari, because we know that our patients are staying much longer than our usual patients with acute respiratory failure, so non-COVID acute respiratory failure. They're staying longer in the intensive care unit, and they're staying much longer in hospital. And they're also without their family, which has been probably one of the most distressing things for us as clinicians, and definitely, extremely distressing for the patients and their families as well. So I think the journey is quite complex. I mean, obviously they come in, if they're critically ill, they may know a little bit about the beginning of, the admission, but they are quickly usually, sedated and ventilated if they're going to be there for a long period. And to be honest, when they wake up, it's very confusing for them. They often have no memory of how long they've been there or what's happened to them. They don't understand why their family isn't with them. And they have no good ongoing memory. So they have very short-term memory. So you have to keep reminding them, often every time you speak to them, you have to remind them where they are and why they're there and why their family isn't there. So we've done a lot of telehealth, getting families up on the screens via iPads so that they can have some time with their families. But from a physiotherapy perspective, it's been it's been a real privilege to be able to follow their journey. And it often is a really long and hard journey. The patients who stay a long time in ICU often have ongoing disability. 30% of them have ongoing disability at 6 months from our Australian cohort anyway. So what we're finding is that there's an awful lot of rehabilitation input. So it's not just the acute care of them that's important. We start early rehabilitation in the ICU as quickly as we can. As soon as they're stable and we're able to safely move them, we will start moving them. But with the COVID-19 patients, that's been really challenging because they're so compromised with their respiratory function if they're mechanically ventilated, and they're really difficult to move in those early stages. So we rehab them in ICU, we try and follow them onto the ward, we set up a rehab program for them, and we even follow them via telehealth once they're discharged home. But we know that there's, as I said, ongoing disability, ongoing problems. They have 100% of our patients so we followed up a cohort of about 300 critical care survivors of COVID-19, and 100% of them reported ongoing problems with their communication and with swallowing and with physical function. So, they don't just need physio, they need speech therapists, they need OTs. It's a long, slow process, and a large proportion of them had, they screened positive for post-traumatic stress and for, post-ICU anxiety. So, they're complex patients to manage. The families are often equally as distressed and traumatised as the patients are. And there's a lot of work we have to do in this space. And I think that's something that I'm really excited about with the guidelines, that as we get more evidence about rehabilitation and the long-term outcomes, I'm sure that there'll be more to add in the long COVID space.
It seems to me that we've still got a lot to learn, even though in the last 2 years we've learned quite a bit. Steve, I'm interested in your thoughts. What do you think are the biggest gaps in our knowledge? What are the most important unknowns in caring for patients with COVID at this severe end of the spectrum?
It's a good question. A lot of things. I'd love to say it's not, but it's a lot of things. I think, like I mentioned earlier, I think one of the things is we treat all the patients the same, which provides a high level of consistent care. And we're very lucky in resource places like Australia to be able to do that. I guess a couple of things would be trying to nuance that a little bit, because the therapies are, especially in therapies that aren't killing the virus. So these are therapies that are trying to reduce the patient's response to the virus. So it makes sense that that's not going to be the same in every single patient. When you're using an antiviral, it's a little bit different, because, or an antibiotic, for example, you're trying to, kill something in the patient. But when you're trying to modify the patient's response, that response is likely different to an individual patient. So that's where I guess with time, there might be some information that comes out that we could make that judgment, which would be really quite exciting. I think, as Carol said, we've come a long way with ventilatory management of patients and safety around that. One of the things at the Alfred that we're well known for, or notorious for, I'm not sure what you want to call it, we do a lot of ECMO, and many places around the world have done a lot of ECMO. I was talking to a site overseas that is not normally an ECMO centre that had 60 patients on ECMO at one point during this latest pandemic. And, in previous to this, a large ECMO unit might have 5 or 6 patients on ECMO, would be considered a big number of patients. This is a heart-lung bypass to enable, basically patients that have got almost no respiratory function left. So that's a treatment we use, and the outcomes have been reasonably good in Australia for survival from that. But there's still probably a lot to learn about the optimum time of when it should be instituted, the ways of avoiding complications, and the time to separate from these machines is also really important. I know that in other places in the world, we were always very lucky in Australia that we followed other parts of the world. So one of the things, and as Carol said, a lot of the patients in Australia have PTSD. A lot of staff overseas have PTSD as well, because as they learnt more, they were able to treat patients a little bit differently, because in the first waves, in particular in Europe, they had no one knew what to do, obviously. In Australia, we've always been a bit more fortunate. We've been able to follow that, and so been able to institute some therapies, which has been better for the patients and I think better for the staff's mental health. But I think we're still a bit simplistic in how we institute these therapies, and I think with time we could get better at those things. And I guess the final thing would be, most of ICU now, because we don't really have in any therapy, in any disease, so just to make us feel better, I don't think in many diseases there is much disease-modifying therapy by the time someone gets to intensive care. I always do a sort of joke with the registrars that I'll buy them coffee for a year if they can think of 5 things that change the outcomes for patients like exponentially in intensive care, and I've never had to buy anyone coffee for that, because there isn't a lot of things that actually, really change the trajectory. It's mostly around good care and prevention of complications. And I think that's where we've improved a lot, but there's still a lot more to learn about that. So patients that got prone still got pressure sores, nowhere near like they would have in previous times, but there's all those sort of things, and they don't seem as sexy and dramatic to people. But, as Carol said, when you follow patients up later on, they're all the things that make a difference. Did they have PTSD? Did they have pressure sores? Did their joints work afterwards? All those things. We can probably do a lot better with time around those things. And then obviously the number one thing would be that we don't need to work anymore. So if the antivirals and vaccinations work, then I don't need to do anything. That would be the ideal situation that we could learn. So ideally we would be out of a job. Like ideally I would like to move into medical admin and not do anything anymore. That would be the best thing, because if you don't need, most of intensive care outside of sort of major elective surgery is things that, we really rely on public health to stop, and COVID's the best example of that. We've seen the numbers drop right off with vaccination, and hopefully the antivirals start to do that as well for some of the at-risk patients.
Great, thanks, Steve. Carol, thoughts for you about what the still unknowns are?
I think there's a couple. I think that I find the patients with happy hypoxia really interesting, the ones who, are severely hypoxic, and it's very difficult to tell. Normally patients have sign of severe hypoxemia, and, when not to rehabilitate them, when not to move them away from the bedside. But in COVID-19, there's a group of patients who can be really unstable with their levels of oxygen, and it's very difficult to pick on them, to pick it up with them. And I think that, I think we've got a lot to learn about why that occurs and how that's best managed and how we can best monitor it, and whether we can push these patients in terms of rehab or whether they really just need to rest for longer periods of time. Because, definitely in the last wave last year, we left a lot of these patients immobile because we just were, worried about moving them. And I'm not sure if that was the right thing to do or not. And I guess, as I said before, just for me, it's rehabilitation. When you see the long-term consequences of critical illness from COVID-19, what you want to know is how early can you start rehab and how hard can you push them? And, will that make a difference to their longer-term outcomes? And we're not going to have an answer to that question for a very long time.
Sounds like there's still quite a bit of work to be done. So I'm very glad that you're a part of the team that's doing that work and signed up for that. I'm aware that we're at time, so I'll let you go, but thank you very much. I hope everybody's enjoyed this show as much as I've enjoyed recording it. If you've got clinical questions that you'd like our experts to address, please send them through our website or social media, and please share this with your clinical colleagues. Look out for the next episode of Taskforce TV. Thanks, everyone. Thanks, Carol. Thanks, Steve.
Thanks, Tari.
Thanks, Tara.